this talk is actually even a little more exciting because for me because there's a lot of questions and unknowns, and this talk actually was a little frustrating for me to put together because the unmet needs are actually still very great. In fact, really the unmet need is that we're not curing these people, right? That's still the major unmet need. We need to think about the 40 or 50-year-old patient who has high-risk features that we need to cure. So putting this together was exciting in that way, but also a bit frustrating because there's so many unanswered questions. And I listed just some of them here. And in particular, why do people relapse after B-cell receptor inhibitor therapies? Why do people relapse after ibrutinib in particular? And what are the mechanisms of resistance such that are they different enough that you can actually switch to an alternative inhibitor and have an effect on changing the natural history of the disease? And what do we do for those people in particular who relapse on ibrutinib? I told you in the last presentation what we might do for people who are intolerant to ibrutinib, but what do we do when they relapse? Their disease progresses, and maybe what we can do is keep them from relapsing. Wouldn't that be nice, right? And that's where I alluded to as I began about the idea of maybe even maintenance therapy in CLL. We'll talk about that. Well, there's a lot of agents. How do we sequence these agents? Do we have any idea about how to do that? And are the toxicity profiles distinct enough by these agents that we can switch classes and do that effectively and maintain an adequate response? And even more importantly, perhaps in many ways, is how can we actually not make people take these pills every day for quote unquote the rest of their life? Can we actually even stop treatment? And actually, can we work towards curing this? What about novel drug combinations to get more negativity of minimal residual disease? And can CLL become the next CML? I don't think it's that far-fetched, but let's focus on these things and why people relapse on ibrutinib. You probably already know this. There are two major mutations that can develop in the B-cell signaling pathway that can lead to relapse. One is a mutation in the BTK binding pocket. We know that that's shown there as BTK, and there's also a downstream mutation that's in PLC gamma 2. Typically, most all patients who relapse on ibrutinib relapse because they develop a mutation in one of those two enzymes in the B-cell signaling pathway. So we know that when people do actually, I don't have a slide for it, but we do know that when we start seeing these mutations, and by the way, it's not a commercially available test, but at least from a research standpoint, when we start seeing these mutations, it does herald that people will relapse later, not too long later. So maybe what we're thinking of doing is trying to prevent those mutations from developing by approaching this perhaps from a maintenance approach. This is data that came from the German CLL study group that was presented at ASH, showing you that in high-risk patients with CLL, in the upfront setting, they were allowed to achieve a remission with whatever agent the investigator wanted, FCR, BR, which were most of the patients, and then they were randomized to get lenalidomide as maintenance therapy or just a placebo. Maybe this is a way to actually help keep people from relapsing. I won't tell you all about these patients again, as you would expect. Randomized, not a huge number, but 2-to-1, 60 patients in the lenalidomide maintenance approach. They started at 5 milligrams a day for a month. Then if they tolerated that, they went to 10 milligrams a day for, I think, another 4 months. And then if that was good, they went up to 15. Most everybody got to 10 milligrams. And there were a large number of patients who got to 15. It was allowing you to get to 20 or 25, but really no one did that. This is the response to the FCR, BR in the frontline treatment for all the patients. I think this is a really interesting slide for me because it kind of is a little different than what Dr. Erdat showed earlier. So we need to kind of figure that out. We also, I'm sorry, these aren't the responses. Yes, they are the responses. I'm sorry. And, we need to get more people to complete remissions. So that's why the maintenance might make sense. But can you actually do maintenance lenalidomide? It turns out that the biggest reason that people failed this trial, if they were randomized to lenalidomide maintenance, was because of adverse events, not surprising. And if you're on the placebo arm, the reason that you failed was because your disease progressed. So yes, it was true. The lenalidomide could keep disease away, but at least about 1 out of 5 patients had an adverse event that made them have to come off of the maintenance therapy. So certainly that is appealing, but it's only appealing if you can tolerate it. And it's only appealing if it actually makes a major impact. And you can see on the right side of the slide that overall survival was no different if you got maintenance lenalidomide or if you got just observed and obviously retreated with whatever at the time that you relapse. Now, we got to follow people longer. It's a relatively short follow-up, but I would argue at this day and age that lenalidomide maintenance might be reasonable in some very high-risk patients, and I should have really stressed, these are only high-risk patients. These are only high-risk patients. It might be reasonable, but for the vast majority, they're still going to relapse, but they'll still do relatively well. But maybe we need to hit them with a bigger hammer, and the Germans have done that too, and this was also presented at ASH. This was the trial known as the Big Trial, or the Big 2 trial, actually. This was a trial that incorporated bendamustine for debulking for patients who had bulky disease. So that was defined as, I think, 5-centimeter disease or a white count more than 25,000. By the way, remember, this is upfront first-line treatment. So again, bulky disease, 1 to 2 cycles of bendamustine. They also got obinutuzumab and ibrutinib. So if you had bulky disease, you got BIG, G being the obinutuzumab. Again, if you didn't have bulky disease, you just got ibrutinib and obinutuzumab. And then after 6 cycles of treatment, if you had any evidence of minimal residual disease, you could go on to get maintenance therapy with obinutuzumab and ibrutinib. Now, this was an update of the data to the end of induction. We don't really have any data on the maintenance approach. These are the patients, again, in the sake of time, I won't belabor this, but just to say, interestingly, I find it interesting that 26.7% of patients over the age of 70 were entered into this trial. That, to me, is a testament to the incredible power of the Germans to persuade patients to go on a trial, I think. So you can also see the other features there, including a small number of patients with 17p deletions. If you got bendamustine debulking, again, there were most patients who did that. 44 of the patients in the trial had bendamustine debulking. Only, I think, 17 did not. You can see that the response rates there were about 65 or so percent, both in the frontline setting and the relapse refractory setting. So bendamustine looks reasonable at debulking for 1 to 2 cycles. And then if you look at how people did after 6 cycles of the obinutuzumab and ibrutinib, you can see that most everybody, in fact, everybody had a response. The response rate was 100% at the end of 6 cycles of BIG. Again, B for only the patients with debulking. How did they do after that from even a better response? Again, 100% of patients had a response, and many of these patients with this very aggressive regimen had elimination of minimal residual disease. Around 50% in the frontline setting, and a little less, 42% or so in the relapse refractory setting, MRD negative. Now, those are people that probably are going to do very well. What about those others who still had some MRD? Well, they're the ones who are going on to the maintenance, and we don't have that data yet, but it'll be very interesting to see if you could convert any MRD from positive to negative by ongoing maintenance, ibrutinib and obinutuzumab. I should have told you that in that first trial that I showed you, the maintenance lenalidomide, no one in that trial converted from MRD positive to MRD negative. Small numbers, but still not achievable with that drug. Doing this appeared to be relatively tolerable. Again, you're not getting a ton of cytotoxic chemotherapy, so that's not surprising. and the progression-free survival looks good. I'm encouraged by that. But I'm also encouraged by the patients who get single-agent ibrutinib, and if this is going to be a major improvement or not, I'm not sure. What are the take-home messages then for maintenance therapy? I think that in some select high-risk patients, lenalidomide might be reasonable. It certainly gives an improvement in progression-free survival. It does not convert MRD positive to MRD negative, but it's not always tolerable, and it doesn't provide a survival difference, at least that we know of to date. This big kind of approach of giving, again, big therapy, gives lots of responses, in fact, 100%. Many of these people become MRD negative, in fact, about half of that at the end of induction. And the idea of just giving a little bit of bendamustine makes this a tolerable approach. It'll be very interesting to see the maintenance data and the longer follow-up on that. Well, I get back to this idea that people do progress, and we need to know what do you do when people progress on a kinase inhibitor, and in particular, what do you do if you progress on ibrutinib? This is data that Anthony Mato did from University of Pennsylvania. It was published in November in Blood, and it's a retrospective study. This has got a lot of caveats and flaws, as you would expect. But this was a trial that tried to look at people who had to stop their kinase inhibitor and who then transitioned to another targeted agent. In particular, those people who went from ibrutinib to idelalisib, or a small number of people who went from idelalisib to ibrutinib. You can see here that the response rates were about 50% if you switched from ibrutinib to idela or idela to ibrutinib. It was better if you actually switched to a BCL2 inhibitor, and in particular that's Venetoclax, which I'll talk about more in a minute. And very few people responded by switching to another chemoimmunotherapy, but that's largely because they had already failed probably a fair amount of chemoimmunotherapy before. And some of these people were able to just go on to get single-agent anti-CD20 antibody and do relatively well as well. But the point here is that you can get responses by switching from one kinase inhibitor to another if there's reason to. So what is that? The reasons are either you're intolerant or your disease progresses. It turns out the people that get these responses were the ones who were intolerant to the prior therapy. If you progress on ibrutinib and switch to idelalisib, you can get a transient response, but it's going to be relatively short. The people that benefit from a class switch, at least as best we could say in these small numbers retrospectively, are the ones who had intolerance to their prior kinase inhibitor. Well, let's get to BCL2 inhibition. Is this an effective strategy after you fail your kinase inhibitor? Can you get ibrutinib for a long time, and then once you get one of those mutations, switch to Venetoclax in particular? I would guess that probably very few people here have used Venetoclax. Outside of UCLA colleagues, anybody use Venetoclax here? I see 3 hands, so that's incredible. Let me ask, just for the heck of it, who's used ibrutinib here? Okay, you get the idea. Why is that important? This is not a trivial drug, even though it's an oral pill. Herbert alluded to the fact that this is a very, very potent drug, and you have to actually use this drug very, very cautiously. I stress that because it can cause very rapid and profound tumor lysis. So you have to know the issues there, have to be diligent in watching for tumor lysis, and you need to follow this ramp-up schedule. It's true that we haven't seen tumor lysis of significance even really at all once we instituted this ramp-up schedule, but the reason that we don't see tumor lysis frequently or even much at all is not necessarily because of the ramp-up schedule. It's just because we're so diligent in watching these patients and intervene if we see any major problems. Nonetheless, a very, very important drug targeting BCL2. This is an update from Jeff Jones then, looking at using Venetoclax after you fail ibrutinib or idelalisib. This was presented at ASH just in December. In the sake of time, I won't say a lot about the patient characteristics, but I should have actually done better on this slide. Arm A are those people who failed ibrutinib and then went to Venetoclax. Arm B, the 21 patients who failed idelalisib and then went to Venetoclax. Again, some with bulky disease. Again, a fair number of prior therapies, medians of 3 to 4. And most of these patients, again, were refractory to the ibrutinib or the idelalisib. So can you actually do this effectively? If the arm A being the ibrutinib arm, you can see if you went to Venetoclax, you had an overall response rate of about 70%, maybe a little lower with switching to Idela, although I would say that's largely confounded by small numbers, around 60% in this study, and some people, but not many, getting complete remissions, but the follow-up is very short. What was the difference between investigator assessments or independent review committee assessments? It was just little differences in determining CT scan reductions in lymph node mass, perhaps by 0.5 centimeter or so. Again, I think the point here is that you can get responses switching from ibrutinib or Idela to Venetoclax, and those responses can be quite durable. I actually have a patient who I did this with almost 4 years ago who remains on Venetoclax to this day. So you can have very significant durations of response shown here and progression-free survival in this selected patient population. I think it's very important to remember that. And I only say that because if you go back and look at the patient characteristics, some of these patients, prior therapies, 11 or 12, those are people that have a pretty biologically favorable disease that are going to do well for a long time. That's why they've been able to get lots of treatments. But they do progress, and they progress and can get Venetoclax and get responses, and some of those responses can be MRD negative responses. So this is just showing you that some patients become MRD negative after failing ibrutinib or after failing idelalisib. The longer you're on the drug, perhaps that will continue to improve. These are looking at peripheral blood. Actually, we also know that some patients can achieve MRD negativity also in the bone marrow. So what are those takeaway messages? I think that switching kinase inhibitor therapy can lead to a response, but usually it's a short duration for those you're switching because their disease progressed. So kinase inhibitors might be fine for a short term, but they're not going to last. Thinking about going to Venetoclax, however, might be more reasonable after you fail ibrutinib, as an example. So maybe 70% response rate in that setting. You can achieve MRD negativity in at least half of those patients in the blood and some at least in the marrow. We need to follow that and get more data. And I didn't show you the data, but this was extremely well tolerated. Venetoclax is an extremely well tolerated drug. There might be a little bit of GI distress, not a lot. And the major problem is tumor lysis. And if you watch for it closely and you're diligent about it, as was in this trial from Ohio State, there was no clinical tumor lysis syndrome. But even then, we don't want to, give these drugs forever. So can we actually stop these agents? And when do we stop those agents if we can? Unfortunately, we just don't really have any data doing this yet. I have very little data. In fact, I'm going to show you this one abstract where people actually got Venetoclax and rituximab for their relapsed CLL, and they were allowed to stop the therapy at any time they wanted to. It's part of the protocol. You could stop anytime you wanted to. This just shows you that some people getting Venetoclax and rituximab can have excellent responses. In fact, in that relapse setting, maybe about 80 or 90% now. And many of those over the age of 70, a very tolerated regimen, watching for tumor lysis, of course. And about half of those are now achieving complete remissions. So the responses are excellent. But again, can you stop the drug? It turns out that of the 11 patients who there were 11 patients on this trial, not a large number. There were only 49 patients on the trial, but 11 of them at the time of this report stopped the Venetoclax. 9 of those 11 were MRD negative. 2 of those patients were MRD positive, all of them in a complete remission. So a lot of patients said, hey, I'm in a complete remission. I want to stop the drug. Sounds reasonable, right? In fact, most of them actually were not only just in a complete remission, 9 out of the 11 were in MRD negative complete remission. It turns out that the 2 patients who relapsed, at least at the time of this follow-up, I don't know longer follow-up, but the 2 patients who were relapsed are the 2 that had MRD positive disease, despite the fact that they were in a CR. Well, that's okay. They're relapsing, right? Why don't we just start the drug again? Well, who knows? Does it work? Well, it actually suggests that it does. Uh-oh, my time's up. This is just looking at one of those patients. The blue curve shows you the MRD levels. So this is a patient who achieved a complete remission, was MRD positive, and then stopped the drug. And the patient was off the drug, I think, for a total of 2 years. So had achieved a great response, off of the drug for 2 years, and then we started seeing MRD positive disease come back or get higher. And that heralded a relapse. The absolute lymphocyte count came back. So the patient relapsed. And the patient got Venetoclax at the time they relapsed. And you can see that the patient had a very rapid, excellent response. ALC went down, and the MRD level actually went back down. That's anecdotal. 2 patients, we don't know if that's always the case. I don't think that's always going to be the case, but in the right patients, this might be a very, very effective strategy. Get an MRD negative, stop the drug. Maybe you're not going to have to take that pill for a handful of years, and then restart the drug if you need to, if and when you need to. I want to be clear, though. That's not the way I do this. I actually don't take people off of the drug. I'd be interested in if other people do. I don't intentionally, but I have had people come off of a drug like ibrutinib or even Venetoclax because of some reason intolerance. So I've had people who have achieved an excellent response come off of the drug because they couldn't tolerate it anymore. And the patient told me, I don't want to go do something else. I'm in a good remission. And I think that was smart. And so we've just watched them. And many people haven't relapsed yet. So we've got a long way to go. I think the safe thing right now is probably to continue to have people on the drug. But we're getting there. We will know when you can stop this. I think just I'm going to cut into the discussion just for a few minutes, if that's okay, because I think this is exciting too. We know in oncology that single agents are not the answer. It's always combinations that are going to make the major difference. And that's probably no difference here in CLL. So what about novel combinations? And you could think of a zillion of them. And really what we would like to see is in the right patients where it's important and meaningful, the 50-year-old patient with aggressive CLL, can you get more people MRD negative that would have an impact on the natural history of the disease? So Ohio State and Jeff Jones has done this study. It was reported at ASH. It's not a large number of patients yet, but it's still interesting of a combination of obinutuzumab, ibrutinib, and Venetoclax. So now use those 3 new novel drugs as a combination. I'm not asking who's going to pay for this. Somebody else is going to have to figure that out. Well, that's our president will figure that out. But this is the schema with a ramp in of each drug to try and prevent tumor lysis. I won't belabor these patients and the characteristics here. You can see that they're largely patients who are motivated to get on a clinical trial with relapsed. Relapse refractory disease. And this is an assessment after 9 cycles for patients who were able to get there. Not a large number of patients, but the people who got out 9 months of obinutuzumab, Venetoclax, and ibrutinib, every single one of them had an excellent response. And you can see many of these patients got complete remissions. That'll probably improve over time, not surprisingly. But I think most interesting is that a fair number of these patients actually achieved MRD negative status in the blood and the bone marrow. Now you got to do more bone marrows, and no one likes all that, but we'll get more data, and that does seem to be appealing as a non-chemotherapy regimen to achieve MRD negativity in a large number of patients. And it's tolerable. These drugs, we all know, are usually pretty well tolerated, and that's what we've seen here looking at the grade 3-4 adverse events. So novel combinations, I just showed you one of them for sake of time. This is an approach that has been well tolerated. We haven't seen dose-limiting toxicity. It was just to ramp up the Venetoclax, and now it's stopped and going on at the standard dose of 400 milligrams daily in the recommended phase 2 dose. Again, the adverse events that you see are really unique to each individual drug, and it doesn't appear that the combination led to a cumulative effect. And there was MRD negativity in a small handful of patients, but 7 out of 10 in the peripheral blood and 4 out of 10 in the bone marrow, and that might even be more if we can get more bone marrows done. So my closing thoughts on these 2 talks for CLL. I'm sorry I've gone over for a minute or 2, but I think it's very important to continue to remember the median survival of this disease is still very long. We, even though now have 5-year follow-up data of ibrutinib, that follow-up is still relatively short. So we need to follow people long periods of time, but it does appear to be encouraging. We can increase CRs over time, but we're still not getting enough people to complete remissions, and relapses are still going to occur. So CLL is not CML, at least not yet. We got a lot more work to do. How do we do those? We need a lot more combination trials. The single agents are not the answer if we're going to get to CML achievements. We need a lot more early randomized trials with novel agents and monitor specifically for MRD. I think Herbert's going to talk about Richter transformation, so I didn't do that, but we need very important studies for Richter, and I didn't touch on CAR T-cell approaches, but you'll hear more about that, I think, from Dr. Timmerman later. So maybe in the future, CLL will be the new CML. We're just not quite there yet. And that's it for me.